Good afternoon. Welcome to this presentation where we're going to have a clinical conversation around the intersection between cardiovascular disease and diabetes. My name is Ted Okerson. I'm an internal medicine physician and a diabetologist. Spent about half my career in clinical practice full-time, and the other half of my career with industry, mostly in clinical research and medical affairs. And I currently work with AstraZeneca, who is the sponsor of today's program. So, if I can get this to move forward, typical disclosure, this is intended for medical education purposes only. What are we going to talk about today? What are our objectives in these 45 minutes? So, one of the things we need to understand is when do we assess cardiovascular risk and renal risk in our patients with diabetes? And I might say a good time is when they see you in the office. You should assess their risk. And then based on what you assess to be their risk, what are the appropriate treatment choices based upon that risk? And then finally, of course, we still need to consider glycemia and concerns around glycemia, hypoglycemia, and the risk associated with hyper and hypo. So our table of contents, a bit of background, and I know that sounds basic, but actually that background I think you'll find very impactful as to understanding how do you look at the data in cardiovascular data, renal data. And then we're going to highlight some of the key aspects of what our guidelines tell us about how do we assess risk and how do we treat those risks by both the American Diabetes Association, by ACE, but also by the cardiovascular associations, ACC and AHA. They're getting in on the Act 2 and looking specifically at primary prevention of cardiovascular disease in our patients with diabetes. So let's look back a little bit of history. For those of you who are interested in history, this is very appropriate, but it actually helps to inform us as to where we are today with our cardiovascular outcomes trials. So back in the, starting in the 90s and going on through the early 2000s, there's been a lot of conflicting data from a cardiovascular perspective as to agents and their risk or benefit on cardiovascular disease. And then back in the mid-90s, the FDA agreed that for all new drugs for the treatment of diabetes, A1C would be the standard by which those drugs would be approved. But then, come along the early to mid-2000s, an analysis of TZDs by Steve Nissen and colleagues called into question the safety of particularly rosiglitazone. And as you remember, those of us who were around, that was a big controversy. There was even a debate at the American Diabetes Association. And largely those data have now been proven to be incomplete. And of course, rosiglitazone is back on the market, but almost never used. But what came out of that was that the FDA issued a guidance to pharmaceutical companies that in addition to just showing A1C benefit, that a drug lowers A1C, but also that we needed to establish that whatever we used to treat diabetes, that there was also cardiovascular safety. So it didn't have to show benefit to the cardiovascular system, just cardiovascular safety. And that guidance came out in the late 2000s. And this applies to both pre-approval and post-approval. So as a result of that guidance, now we have a whole host of cardiovascular outcome trials, and these are somewhat highlighted for you here and color-coded. The first ones to come out are those in the left on the light blue, those DPP-4 inhibitor studies, which largely showed no risk but also no benefit as well. And then at the bottom we have, I'll just call it a token study for pioglitazone, for insulin, and also for acarbose in the colors there at the bottom. But the bulk of the studies that you see on this slide are in the darker purple, so the SGLT2 inhibitor trials, as well as with GLP-1 receptor agonists in the light tan color. So a whole host of studies that have come out to help inform us of cardiovascular safety, which these studies largely did. But then we developed something else out of all these studies that in some respects was somewhat surprising, and a number of these agents have now shown cardiovascular benefit. But out of those studies, out of that guidance where we required to show safety, we actually found some additional information where we may not have even expected it. And And as a result, there continue to be ongoing studies, not just though looking at cardiovascular outcomes as a MACE endpoint, cardiovascular death, MI, stroke, but actually looking at effects on protecting the kidneys, effects on heart failure, both reduced ejection fraction as well as potentially preserved ejection fraction. So there is a wealth of data that we've already acquired, but there's also a wealth of data in specific cardiovascular and renal populations where we may see benefit from some of these other drugs, that these studies are actually powered to look specifically at this benefit. But what is the issue within all these trials? How do we interpret them? How do we compare from one compound to another across a plethora of different clinical trials? And one of the difficulties in doing that basically comes in the design. And so on this slide, we look at the two main classes of agents that were on the previous slide, the SGLT2 inhibitors and the GLP-1 receptor agonists. And on the left are four of the outcome studies with SGLT2 inhibitors. And what's different about these studies is the level of risk or the level of cardiovascular disease in each of these studies. So the populations are different. Why is that? So as a general rule, when you're doing a cardiovascular outcome study, whether it's in diabetes drugs or lipids or other compounds, sponsors of these studies typically try to study high-risk individuals. Why is that? One, they typically have a higher event rate, and because these studies are event-driven, once you hit a certain number of events, you stop the study. Because they're large studies, if these go on for a long period of time, they tend to be expensive. So they typically try to enroll higher-risk individuals. The other aspect of that is that these higher risk individuals have the potential to have a greater benefit. So as a general rule, sponsors of studies tend to like to study higher risk folks. Now with the SGLT2 inhibitor trials, you see EMPA-REG and VERTIS, which virtually everybody in that study had established cardiovascular disease. They'd had an MI or a stroke or a TIA or peripheral vascular disease. And then the other two studies, CANVAS and DECLARE, you had a mix. So in DECLARE being the lowest, with barely 4 out of 10 patients having known cardiovascular disease. And the GLP-1 receptor agonist studies on the right were really no different, because here you see studies that were like HARMONY, where everybody again had known cardiovascular disease, and then the other trials with various percentages of mixes with those who have, quote, risk for cardiovascular events versus those where we know have risk or have had events. So it makes difficulty in comparing the different agents and the different studies in each of these classes of drugs. So in an attempt to try to answer that question, what investigators will often do is try to advance to the next slide, is to do a meta-analysis. And so on the top, this is a forest plot that looks at the GLP-1 receptor agonist studies. And let me just kind of level set for everybody. I know some of this will be review, but it's really important because actually a lot of clinicians do not understand how to interpret a forest plot. So I just want to review that with you briefly. So there in the middle, there's a vertical dark line that's called the line of unity. And if the confidence interval, that horizontal purple line, touches that line of unity, then that result is considered not statistically significant. Okay, so that's one component of a forest plot. Then those big purple squares, that's called a point estimate. It's basically like the mean. And if that point estimate is to the left of that line of unity, that shows benefit for that treatment, which in this case is GLP-1s. On the other side, if the point estimates were there, it would show that the placebo is better for whatever you're studying. So how do we use these forest plots when you're doing a meta-analysis? We want to look at the totality or the consistency of the data. And what you'll see here is all the point estimates are to the left of that line of unity, indicating that there is a benefit to the use of GLP-1 agonists in the MACE events, that 3-point MACE that we talk about. And you remember I told you that the studies with higher risk populations tend to show greater benefit, and indeed this meta-analysis kind of points that out. So if you look at SUSTAIN, HARMONY, PIONEER, those point estimates are a little bit farther to the left than the other studies. But then that diamond shape at the bottom is looking at the overall totality of these studies. show benefit by using a GLP-1 receptor agonist. Now, in contradistinction to this, the two forest plots below, in the kind of reddish purple and the blue, those are SGLT2 inhibitor outcome studies. In the purple is those who have established disease, and you can see there, point estimates again are to that left of line of unity, showing that overall, this class of drugs seems to benefit patients who we know have established disease. But what about those who are just at risk for disease, who have risk factors? Well, there you see that point estimate is right there on the line of unity, so that doesn't appear to be a benefit. Now, there's one more component of forest plots that I want to inform you regarding, and that's to the right, something called the P for interaction. And what that is a statistical test to see, is there a difference between those two groups? If the p-value is significant, then it's not conclusive, but now you can generate a hypothesis as to if these two groups are different, why are they different? And then you can design a study to try to answer that question. If, on the other hand, that p-value is not significant, then that would suggest that there is no difference between the two different groups and that the results apply to all groups. So let's look at a couple of, I won't say exactly surprising, but some of the other features that we found in outcome studies. And specifically, in the SGLT2 inhibitor studies, there was a somewhat surprising, for some folks, reduction in hospitalization for heart failure. And this is very, very important because we all know in our practices, hospitalizations for heart failure are one of the most common reasons for hospitalization, specifically in a Medicare population, and they're also expensive. But the data here, as opposed to what I just showed you in the 3-point MACE, when you look at hospitalizations for heart failure, whether patients have known atherosclerotic cardiovascular disease or whether they're at just risk for cardiovascular disease, you can see that the point estimates are to the left, that both these groups appear to benefit in reducing the risk of hospitalization for heart failure. And I want to point out, remember that some of these patients, there was no known cardiovascular disease, yet we reduced hospitalizations for heart failure in this patient population. And then the P for interaction, non-significant, showing that the benefit is similar in both these groups. What else did we see from the clinical trials? We saw renal composite events being decreased. And in similar fashion to the hospitalizations for heart failure, you can see again the point estimates in our SGLT2 inhibitor outcome studies are all to the left, showing benefit in both patients who have established disease that we know of and those who are just, quote, at risk for disease. And as a result of these studies, these endpoints were not the primary endpoint. The primary endpoint of our outcome studies were those MACE events. But because of these data, now we have to test this hypothesis. So the studies that I showed you in that big timeline, now we have studies actually looking at hospitalization for heart failure outcomes as well as renal composite outcomes as the primary endpoint. So really exciting times. So given all of these data, how do we manage hyperglycemia in these patients? So let's look at the ADA standards of care. And this is a big, busy table, but I'm going to break it down for you. So initially, what the focus based on these outcomes trials is this group here. I'm going to show you a blown up version of this in a second. So let me just touch on these other groups. So the first is a compelling need to reduce or prevent hypoglycemia. The word compelling, you'll have to interpret that how you want, but I know in my practice I typically try to avoid hypoglycemia. Not only is it potentially harmful to patients, an increase in glucose variability we know seems to be harmful as well, but also what do we know from an adherence perspective? If you have a patient who experiences significant hypoglycemic events, or one event even, what are they going to do? They're going to be less likely to take your medication, or if they take your medication, they may eat more to prevent hypoglycemia. And so we get in this circle where now they're going to gain weight, or they don't take our medications and the A1C isn't where we want it to be. And similarly is a compelling need to reduce weight. We know that most of our patients with type 2 are overweight or obese. And I know in my practice, typically when I prescribe a drug, I'm thinking through how does this best fit in that patient's lifestyle and what additional potential benefits can I get from this compound? So here, when we have patients who weight loss or weight neutrality is beneficial, these are an indication where we should consider these classes. And then finally, the guidelines talk about where cost is a major issue. And that's referring to the cost of a medication. It doesn't look at the entire cost of taking a specific drug, the cost of a severe hypoglycemic event, for example. One little pearl, if you will, it's also a pet peeve of mine, but a lot of my colleagues in practice, they make the assumption that a therapy, whether we're talking about diabetes or lipids or blood pressure or anything, they make an assumption for the patient that it's too costly, whereas now with all the talk about shared decision making, what we really need to be doing as clinicians is talking to the patient. Here's what I expect out of this drug, why I would choose it for you, here's the risk, benefit, here's the potential cost, and let the patient come to a shared decision with us as to whether something is too costly or not. But given the focus of our discussion, let's kind of drill into what do we do for patients from a cardiovascular or renal perspective. So of course, lifestyle is foundational, but we also know that our patients tend not to do that very well. And then metformin, if you have a patient with established cardiovascular disease and that's the predominant problem, the ADA guidelines suggest that we should either use a GLP-1 receptor agonist or an SGLT2 inhibitor initially in those patients after metformin. And if you still need additional A1C control, you can add the other agent. So those are in patients who we know have atherosclerotic cardiovascular disease. Now we also should still remember though that a lot of our patients with diabetes, particularly those that have had it for 5 years or more, probably have some sort of cardiac dysfunction. But then if we know they've had heart failure or a history of heart failure, or they have chronic kidney disease, so their eGFR is 60 or less, you should use an SGLT2 inhibitor first because of what we have seen so far in the outcomes trials. And then if an SGLT2 inhibitor is either not tolerated or it's contraindicated, you should consider using a GLP-1 receptor agonist. So clearly in the ADA guidelines, these two different classes of agents are now elevated significantly because of the additional potential benefits these can give. What about the ACC and AHA? Even our cardiologists are getting in on the act. And what they say, of course, is if you have a patient who's consistent with diabetes, you do the diet, the exercise, you aggressively treat other risk factors. And I think this is important for us because statins, for example, in patients with diabetes are largely underutilized until they have an event. We want to prevent that event. But then the cardiology guidelines say if the A1C is still above 7, you need to know, does the patient have significant or other cardiovascular risk factors? And if so, consider an SGLT2 or a GLP-1. I actually kind of like the box on the right. If they are above 7 and they don't have risk factors, just send them back to the primary care. I don't want to deal with it. And then finally, the ACE guidelines. Now, this is great for people who love the pastel colors. I actually like these guidelines because I think they're very easy for our clinicians to follow. And what do they say? Well, again, lifestyle is important, metformin initially for most patients, but in monotherapy, you could also choose an SGLT2 or a GLP-1 for monotherapy for treatment of diabetes. And then if your entry-level A1C is 7.5 or more, you can consider using 2 drugs to start. And I know in my practice I've even used 3 drugs if the A1C was high enough right off the bat, if the patient would allow it. So when you use dual therapy to start, as according to ACE, metformin plus an SGLT2 inhibitor or metformin plus GLP-1 or the combination of the two combined. And then the other thing that the ACE guidelines do for us, and I'll go through this, is they also give us a full chart looking at all the classes of agents used to treat diabetes, and they highlight the cardiac aspects of them as well as the renal and genital urinary aspects of each of these compounds, which helps us make a more informed decision. So this ends the didactic portion. What we've learned is that guidance for industry that came out in 2008, which some people were perhaps less enthusiastic about, has actually turned out to be a good thing because we've learned so much more about these agents and potential benefits for patients. So not only have these two classes, SGLT2 inhibitors and GLP-1 receptor agonists, demonstrated positive cardiovascular outcomes, but now there's the potential for other benefits as well. And finally, the guidelines actually support the early use of these compounds in our treatments for diabetes, and this is especially true in patients who have established disease. So with that, I'd like to call up a couple of panelists, and we'll talk to them, answer them some clinical questions. So first off, I'd like to introduce Curtis Triplett, who's a PharmD and CDE, Associate Professor of Medicine at the UT Health System in San Antonio. He currently works at the Texas Diabetes Institute, which is part of the University Health System in San Antonio, Texas, where he works both in diabetes research as well as in a clinic seeing patients jointly with an endocrinologist. Evan Sisson is a PharmD, CDE, AADE. He's a professor at the VCU School of Pharmacy. He also works at a free clinic in Richmond, where he teaches diabetes care to medical students, pharmacists, nurses, and he also co-manages the clinic with a medical director. So welcome, thank you for joining us in this discussion. So we will have time for questions from the audience, but before we get there, a couple questions. I know with SGLT2 inhibitors, sometimes clinicians are, especially the primary care side, tend to be a little bit shy because there's an initial dip in GFR, and they see that in their charts. Can one of you like to explain why that is, and should that be something that we're concerned about?
Okay. So I think with any diuretic, you're going to see a change in kidney function. And so the way that I think about this change in kidney function with the SGLT2 inhibitors is similar to what happens with ACE inhibitors. You know, ACE inhibitors are working on the efferent arteriole to decrease pressure through the glomerulus. And for those patients that have decreased throughput through the glomerulus, you may see a rise in creatinine. Usually that is a transient change that will resolve in a couple of days. But if it persists, then that would suggest that this patient is not going to be able to tolerate the drug. The same kind of thing is happening with the SGLT2 inhibitors, except on the afferent side. But the end result is decreased throughput through the glomerulus. For those patients that are able to compensate for that, then this decrease in pressure inside the capsule is actually going to be protective. And I think we see those results in the outcomes trials. So to me, what this means is that we need to be monitoring these patients and know what the baseline kidney function is, and then follow up with them, and not just blindly start medicines.
Thank you. So Curtis, are you starting to give these patients to your patients with renal insufficiency? Are you giving the SGLT2s or GLP-1s?
So I think it's a great question. So as you guys know, the data is coming out that, and he just showed you that the SGLT2s and GLP-1 receptor agonists are both seem to be positively affecting the progression on of renal disease. And I think it's important to understand how you kind of place them and how we place them in clinical practice. So we are using both in clinical practice, but we also have to realize, and something everyone here knows, that as the eGFR goes down, the glycemic effects of SGLT2s decline. And so you have to kind of balance that of why you're using these drugs. So it's clear that the SGLT2 inhibitors help decrease the progression of kidney disease. But as you get into this range, down to 60, 45, I don't think there's any question for glycemic control and things like that. But below 45, you're now getting into the range where the A1C reductions are less than 0.5. So you need to look at your patient. If you're choosing the SGLT2 inhibitor and you're trying to do both, you're really like, I want the glucose to be at this and I want to protect their kidneys, I think your SGLT2 inhibitor is a great choice. But then there's this tipping point where you have to realize if you're not fairly close to goal, then I think you should be considering a GLP-1 receptor agonist. And remember that the GLP-1 receptor agonist A1C efficacy is not affected by your eGFR. And so you have to remember that one, now you can go down to an even lower eGFR and still get efficacy. Now, just to make sure we're all on the same page too though, it's clearly been shown the lower your eGFR is, there might be a slightly higher risk of GI side effects with the GLP-1 receptor agonist, and you balance those two in clinical practice. So we kind of use one or the other. A lot of our patients, to be honest with you, if we can, we get them on both. So I think that in your clinical practice, you have to kind of decide how to balance those different aspects of the drugs.
Excellent. So Evan, shifting a little bit more over to the safety side, how do you respond to a patient when they're concerned about the potential for genital urinary side effects with the SGLT2s?
Sure. Well, I think the way that this class of drugs are working is they're increasing urinary excretion of glucose. So initially, when the class came out, we were concerned about urinary tract infections and fungal infections. Fortunately, the urinary tract infections don't seem to be, the frequency is not as common as we would think or thought it would be at the beginning. However, I had a patient who was 325 pounds, African-American lady in her late 40s, put on an SGLT2, and it had a history of fungal infections. And so we talked about it and went ahead and started the medicine, and she came back 2 months later and said, yep, I think I have a problem. And so we recognized that what was going on, and so decided that rather than continuing on, that we would switch over to a GLP-1 instead. And so it does happen. I think the fungal infections are real, and easily managed. But I think for those patients who are overweight, have a history of problems with fungal infections, that it's something to consider in making the drug therapy selection.
Okay, thank you. So, Curtis, would you prescribe one SGLT2 inhibitor over another in a particular patient based on their cardiovascular risk?
The quick answer to that is no. As Ted has eloquently shown you in the slides, I think the devil is in the details of the studies. It's clear that the baseline characteristics of risk tell you the outcome of the trials. And we didn't know that. You have to remember, when the trials were designed a long time ago, people didn't know these kinds of details about what was going to come out. And so people chose different populations to look at different outcomes of cardiovascular risk. What is clear now is that the higher your cardiovascular risk, the more potential benefit you'll get from an SGLT2 inhibitor. So when you look at the trials, like an EMPA-REG trial that had 99% of all the people that had cardiovascular disease in it, you're going to find more benefit because they had a higher number of people at baseline with cardiovascular disease. Move that dial over to something like Declare TIMI, and what you're going to find is that the dial goes a little bit different, just because of the fact that their baseline characteristics were different, as far as less people with established cardiovascular disease and more with multiple risk factors. We now know that based on that data, that secondary prevention is the core group of people that we're going to target for using SGLT2 inhibitors.
Thank you. So Evan, what about DPP4 inhibitors? What is their role in patients who have established disease?
Well, I think DPP4 inhibitors are still an option for patients, but the data from a cardiovascular standpoint is just not there. And so for those patients with existing disease, the SGLT2 inhibitors and GLP-1 agonists are going to be the agents that we're going to look to first. And I appreciate the ADA guidelines now identifying that and helping folks in primary care to know, okay, this is where we need to be heading. And not only to think about glycemic control, but think about cardiovascular disease at the same time.
Okay. Thank you. So Curtis, are you telling your patients about DKA, about Fournier's gangrene?
I think you have to inform your patients about these kind of things. So as a follow-up to what Evan was saying, you have to teach them about mycotic infections, and I think it's a simple one-sentence help to them to say, and if you would have pain down there, you should seek treatment even sooner. Just remember that the Fournier's gangrene is so rare that I just think that to tell them more than that would be overkill. But I think if you just tell them in your mycotic infection little statement that you tell them, because it's really about pain down there and just seeing one more step. And what was the other part that you
The
said?
DKA?
Oh, the DKA. So I think that more than telling them about DKA, we tell them, if you feel very sick, this is what we say. If you feel very sick and you can't eat or drink, it's time to temporarily stop your SGLT2 inhibitor. And just do it for a couple of days. When you're feeling better, just restart it. And I think that that's a safe way of moving forward. When we're using it in combination with insulin, of course, you go into your sick day management that we all as educators go into. And I think as long as you do that and understand that stopping the medication for a couple of days is not going to be something bad for the patient.
Okay. Excellent. So we talked a bit about some of these risks. We talked about the GFR changes. What monitoring strategy, Evan, is best when you start an SGLT2 inhibitor? How do you monitor those patients over time?
Sure. Well, I think it's prudent to get a baseline creatinine and make sure that you know where the kidney function is. And from there, it depends on the patient. Mm-hmm. My parents just returned from a cruise in Russia, and they're 76. They would be people that I wouldn't be too worried about, but I see patients in clinic that are 46 that look really, really old. And so those are folks that I'm going to see back sooner and do follow-up labs to measure their kidney function and monitor what's going on with the SGLT2s.
Okay. Well, we've talked also a lot about patients with established disease, and we know that at least there may be a suggestion that, particularly with SGLT2s, they may not be as beneficial in primary prevention, yet the cardiology guidelines suggest that we should consider using them. So Curtis, do you guys use SGLT2s in primary prevention?
Well, I think that you have to flip that script a little bit, and you have to say, do we use SGLT2s and GLP-1s in patients that don't have cardiovascular disease? And the answer is obviously yes, for the multiple risk factors that they address. Mm-hmm. So I don't think that you can just say, oh, well, you don't have cardiovascular disease, so this is not your optimal drug. Even if you look at the guidelines, it's clear that they're listed second or third line therapy. They're listed as one of the drugs for hypo, for weight. And so those are the key kind of places we use it. Obviously, SGLT2s lower weight, help with blood pressure, have multiple things that they can do for you. And that's true of GLP-1s too. They lower weight. If your blood pressure is elevated, they can help lower blood pressure. And so there's multiple things that you can think about these drugs doing for your patient, which we are familiar with, even though we're not directly maybe affecting a large part of their heart disease risk. Obviously, there is some evidence too for SGLT2s preventing heart failure. Mm-hmm. So I think that it's hard to pinpoint that patient and say this is the one that's going to get the heart failure, but if you can pinpoint that person, SGLT2s have been shown to decrease the risk of that as well.
Excellent.